Okay. Last time we have discussed the diabetes mellitus. Now, as we discussed that the diabetes in the pregnancy is divided into the pre-existing diabetes mellitus and the gestational diabetes. We discussed the pre-existing diabetes, and now today the discussion is on the gestational diabetes. What is the definition? What is the difference between the gestational diabetes and the pre-existing? As you know, we discussed that the pre-existing diabetes means patient already known to be the diabetic. She is known to be the diabetic. It could be the since few years, few months, or the since birth. This is a depend upon the type of the juvenile or the maturity onset diabetes, but she is known to be the diabetic. And she could be on the either the oral hypoglycemic or on the insulin or on the diet controls. This depends upon the level of the sugar. While the gestational diabetes, this is very important to understand the definition of the gestational diabetes. That is, the gestational diabetes may be defined as carbohydrate intolerance of variable severity with first onset in the pregnancy. Means इसका मतलब ये हुआ कि कार्बोहाइड्रेट इंटॉलरेंस ऑफ वेरिएबल सीवियरिटी का मतलब है जो हमारी कट ऑफ है उससे अगर 10 मिलीग्राम भी लेवल ज्यादा हुई किसी भी टाइम पे ड्यूरिंग द प्रेगनेंसी उसको आप यू हैव कंसीडर्ड दैट द गेस्टेशनल डायबिटीज उसको आप लेबल कर देंगे कि ये गेस्टेशनल डायबिटीज है क्योंकि देखें और दिस डेफिनेशन इज इररिस्पेक्टिव ऑफ वेदर द पेशेंट So, hyperglycemia in the postnatal period or patient is diabetic prior to the pregnancy उसको पता ही नहीं था कि वो diabetic है first time उसका diagnose हुआ है pregnancy में तो आप उसको gestational diabetes ही label करेंगे हालांकि हो सकता है कि वो पहले ही diabetic हो लेकिन क्योंकि उसने कभी investigate नहीं करवाया उसको पता ही नहीं है उसका first time investigation में for example random blood sugar raised आई है तो हम उसको लेबल करेंगे gestational diabetes unless it is proven. So some of these patients may have previously undiagnosed diabetes and sometimes these patients may have the altered glucose tolerance after the pregnancy as well. Now, what is the prevalence of the GDM? The prevalence of the GDM is nowadays is very increasing, particularly in the Asian countries. So the prevalence of the GDM varies with the diagnostic criteria used and with ethnic groups. अब देखें कि there are the different diagnostic criteria. NICE guidelines हैं, SIGN guidelines हैं, WHO criteria है और AIDS PSG है. तो ये different जो है, these are the diagnostic criteria. तो overall जो है WHO ने इंटरनेशनल डायबिटिक एसोसिएशन स्टडी ग्रुप जो है उसको अडॉप्ट किया हुआ है और जर्नलाइज हो या फिर नाइस गाइडलाइन चल रही है द अमेरिकन एसोसिएशन आल्सो अडॉप्टेड द WHO क्राइटेरिया एंड व्हाइल द नाइस गाइडलाइन इज समवट डिफरेंट फ्रॉम द WHO guidelines. The prevalences are high in India, Asian countries, high in India, in the Bangladesh and in the Pakistan. And it has been seen that there is a relative risk 7.6 to 11-fold higher in the India, Bangladesh and Pakistan compared with the white and the black women. And then in them, the relative risk is 3.1. So we people are very at the high risk of this GDM. And this overall prevalence जो GDM का है, that is a 1 in 5%. वो तो हमने पहले भी डिस्कस किया था कि ओवरऑल डायबिटीज का रिस्क भी इतना ही है तो GDM का भी ओवरऑल रिस्क इतना है लेकिन दिस इज डिपेंड अपॉन द एथनिक ग्रुप्स और ये दिस इज पर्टिकुलरली हाई इन द बांग्लादेश इन द इंडिया इन द पाकिस्तान. We have the 7.6 to 11-fold increased risk as compared to the white and the black population. This is because of the genetic or this because of the lifestyle modification. Now there are certain risk factors for the development of the GDM. अब देखें कि for example if there is a body mass index more than 30 kg per meter square, there is a 20 to 30% increased risk of the developing the GDS if the female enter in the pregnancy with a body mass index more than 30 kg per meter square, then she has 20 to 30% chance that she developed a GTM. Similarly, if there is a history of the previous macrosomia, infant means their baby's weight is more than 4.5 kg, then again she has the increased risk. It could be the 30 to 50% chance that she again have the macrosomia and that she can have the GTM. Patient have the previous history after diabetes. This is gestational diabetes. अब देखिए कि इसका तो इतना ज्यादा रिस्क है if the patient having the previous gestational diabetes in the previous pregnancy, there is a 30 to 85% risk the patient may have again the gestational diabetes in the current pregnancy if she have the history of the GDM in the previous pregnancy. If the patient's first degree relative is suffering from the diabetes mellitus, again she has the increased risk. Ethnicity, as we discussed, that if you belong to the Pakistan, Bangladesh and India, there is a 7.6 to 11 to 12% risk that these patients having the GDM. Southeast Asia, India, Pakistan, Bangladesh, Black Caribbean से, Middle Eastern है, South Arabia, United Arab Emirates, Iraq, Jordan, Syria, Oman, Qatar, Goa, Lebanon, Egypt. All these patients, all these areas belong to the high risk group. So this is a high risk group in which the GDM is more common. Now, how we do this diagnosis and the screening for the GDM? Previously, there are the many tests for the screening and the diagnosis. There are the separate tests for the screening and separate tests for the diagnosis of the GDM. But that include the history of the patient, that is the high risk group, as we discussed, the risk factor, the random blood sugar, the fasting blood sugar, the glycosuria, the GCT, glucose challenge test, all these were the screening tests and then the diagnostic. But nowadays, according to the AIDS PSG, a sign and NICE guideline, AIDS PSG and sign and WHO is the same guidelines, while NICE guideline is somewhat different. So all these agreed that there is no need of the separate screening for the GDM. It's a one test which is a diagnosis test, and that test is known as the glucose tolerance test, or OGTT. What is OGTT? OGTT, oral glucose tolerance test, in which we ask the patient to have the normal diet in the night, and she should be fast from the 12 p.m. and she have the fasting blood sugar, and then she have the 75 grams of the glucose orally in a 1 glass of the water, 100 ml of the water she should take in the 10 minutes duration. And then one can have the blood sugar after the 1 hour, and then after the 2 hour, after according to the ISPSG and sign guideline, and 2 hour after the NICE guideline. NICE guideline do not require the 1 hour postprandial, but it is only recommend the 2 hour postprandial. So all the patient, according to the NICE guideline, this screening should be performed only in those patients who have the risk factor, as we discussed earlier, and it should be performed at 24 to 28 weeks of the gestation. While ISP, because of the after the HAPO study, a HAPO study is a hypoglycemia and the adverse pregnancy outcome. It's a study which was conducted in the worldwide and on the 23,000 patients, in which they have seen that the different glycemic level, different level of the hyperglycemia and the effect on the fetus and the neonate. And these effects are the outcome variables were macrosomia, shoulder dystocia, increased risk of cesarean section and neonatal hypoglycemia. तो उन्होंने देखा कि variable levels जो हैं that will also affect on the outcome, variable outcomes जो हैं उस पे affect कर रहे थे. So that's why they asked that there should be generalized screening for all the patient, all the pregnant patient at the 24 to 28 weeks of the gestation, So the diagnosis of the age, we have to belong to the high risk group, and in the areas or in the countries where the or ethnic groups of the where there is an increased risk of this diabetes mellitus. That's why in our population we follow the WHO criteria. That is, all the patients should be screened at 24 to 28 weeks of the gestation by this oral glucose tolerance test, and the cutoff level, as we discussed, is in front of you. That if the fasting level is more than 5.1 millimole venous blood plasma, and the according, and that 1 hour more than 10 and 2 hour more than 8.5, then all these patients should be labeled as a diabetic. According to the NICE guideline, she has the according to the NICE guideline says that the fasting should be more higher level. That is the more than 5.6 millimole. While the NICE guideline do not recommend the 1 hour postparental, but 2 hour postparental 7.8 millimole. So if all these levels are raised, then you label the patient or diagnose the patient as the diabetes, gestational diabetes, and then it is recommended that she should have the hemoglobin A1C. Actually, hemoglobin A1C is not a recommendation for this screening procedure. However, all the patients who have the +2 glucose in their urine, they should have this screening and diagnostic. However, after this we should have the hemoglobin A1C. Hemoglobin A1C show us that for how long her blood glucose was abnormal. That means that the previous record of the glycemic state. So it's we assess that whether she is a diabetic since how long. Since how long? That means there's a 1 month, 2 months, or 3 months. That's why we do the hemoglobin A1C, and the cut of the hemoglobin A1C is a 6.5%. Now, after the diagnosis, what is the management? We diagnose by this, as we discussed, the OGTT, and then confirm it by the A1C to see that for how long the patient was a diabetic. Then the management. We discussed previously, and the pre-existing diabetes mellitus, that the management of the diabetes is a teamwork. It is a multidisciplinary approach. इसमें सबसे जो इम्पोर्टेंट मेंबर टीम का जो होगा, दैट इज द पेशेंट हरसेल्फ. वो इतनी डिटरमिन होनी चाहिए कि उसको पता होना चाहिए कि मुझे किस तरह से शुगर कंट्रोल करनी है, अपनी डाइट में मुझे क्या लेना है, मुझे कितनी देर तक एक्सरसाइज करनी है, हाउ टू ओवरकम द हाइपोग्लाइसीमिया, हाउ टू कंट्रोल द ग्लाइसेमिक कंट्रोल बाय द ओरल और द इंसुलिन, हाउ टू यूज द इंसुलिन, how to use the glucagon. उसको खुद को पता होना चाहिए. If she is not too much intelligent enough, then her attendant, either her husband or her sister or mother, whosoever is living with her, she should be involved in the team. Otherwise, all these patients who are not able to control their blood sugar by their own, they should be hospitalized. Again, in the hospital, there is a multidisciplinary approach that involves the obstetrician, that involves the diabetologist, that involves the dietitian, a special nurse who knows when you should take the blood for the checking the blood sugar, how to overcome the hypoglycemia, and how to use the insulin, and no doubt the midwives. What is the antenatal care? Now, the multidisciplinary approach involves all these persons. If the patient is hospitalized, all these persons have to visit the patient. Otherwise, if the patient is maintain herself, the patient can be asked to come in the outpatient department. The antenatal care in all these patients is required, as you know that the GDM is started from the second trimester of the pregnancy, when the insulin antagonists are released from the placenta. They are diagnosed in the second trimester because the antagonist of the insulin, they are started in the second trimester of the pregnancy, particularly after the 20 weeks of the gestation. So the glycemic control is also difficult because of the release of these antagonists. Antenatal care, as usual, as the patient are non-diabetic, they should come in as they have the, whenever they become amenorrheic, they come to the obstetrician, she confirm her pregnancy by doing the ultrasound examination, and the aim of the ultrasound at 10 to 11 weeks is to confirm the pregnancy, to viability, number of the fetus and other abnormalities. And then she should have the basic investigation like the blood group, RH type, random blood sugar, and the blood CBC, hemoglobin percentage, and viral marker is the usual patient having the investigation. While these patients, if the feto-maternal monitoring is a reassuring and there's everything is normal, patient is a euglycemic, then they are asked to come for the regular antenatal checkup as usual. But she again requires the she should have to visit to the diabetologist, to the dietitian, and to the midwife as well. Yeah, the midwife visit to the female herself, as in other countries, developed countries having the midwife who visit to the home to the patient. While in our setup it is not possible, so they should be patient visit herself to the outpatient department. In antenatal period, our aim, what is our aim? That the patient should be euglycemic. Her level should be normal throughout the pregnancy. Aim क्या होगा? Euglycemic से फायदा क्या होगा? कि we have to prevent the macrosomia, to prevent the risk of preeclampsia, to prevent the unexplained death, which is a common in the diabetes mellitus, as we discussed in the pre-existing diabetes. So keeping the patient euglycemic, we can prevent the macrosomia and all the complication of the macrosomia. That is that there may be the shoulder dystocia, there may be the difficult labor, there may be the obstetric labor, there may be the increased chance of the cesarean section, and the risk of the preeclampsia and unexplained fetal death. How we do the glycemic control? Actually, it is a function of the diabetologist, but you being a doctor, you can advise the patient to have the control by the doing the with the diet, with exercise, and any hypoglycemic agent if needed. What is the diet required? The diet is the carbohydrate diet, but the diet should be it should be that 50% carbohydrate, 30% protein, and 30% fat. No high fat diet is taken. No refined sugar. Patient divide her carbohydrate into the 3 meals and the 3 snacks. Carbohydrate, low carbohydrate जो होते हैं जिसमें like brown breads हैं, like fruits हैं, refined sugar should not be taken. The regular white bread नहीं लेनी है, उसको कोशिश करके वो कहे कि white bread, white rice नहीं देने, brown rice, she can take the brown rice, she can take the brown bread, and she have the regular calories at the regular time, as we discuss in the pre-existing diabetes. In the similar, it's a low carb index diet जो होती है, low carb index से आजकल तो लड़कियां बहुत ज्यादा डाइट कर रही है ना, उनको तो जो कीटो डाइट कहते हैं या लो कार्ब इंडेक्स डाइट कहते हैं. लो कार्ब इंडेक्स डाइट का मकसद है कि जो रिफाइंड कार्बोहाइड्रेट है वो नहीं लेने हैं, लाइक शुगर नहीं लेनी है, लाइक कोई भी मीठी चीज उनको किसी भी फॉर्म में नहीं लेनी है. अगर वो चावल भी लेगी तो ब्राउन चावल लेगी, अगर वो ब्रेड भी लेगी तो ब्राउन ब्रेड लेगी. शी कैन टेक द कार्बोहाइड्रेट. So why we ask the patient to take the carbohydrate, low fat? Because we prevent if we ask the patient to take the, do not take the carbohydrate, we cut off the carbohydrate, there may be the more chances of the ketonuria and ketoacidosis, जो starvation में भी होता है और डायबिटिक में भी कॉमन होता है. तो कार्बोहाइड्रेट तो उनको, अगर हम कार्बोहाइड्रेट पेशेंट को नहीं कहेंगे तो ग्लूकोज कहाँ से आएगा? दैट ग्लूकोज विल बी कम फ्रॉम द ग्लूकोनियोजेनेसिस. आपको पता है कि फैट से ग्लूकोज आ सकता है, एंड देयर में बी द चांसेस ऑफ द ketonuria and the ketoacidosis. So the carbohydrate, adequate carbohydrate, low carb index जो कार्बोहाइड्रेट होते हैं वो लेनी है इनको, and refined sugar नहीं लेनी है, adequate protein and adequate fat. That will causes the good growth of the fetus, but not the macrosomia. and this be divided. Patient should not be fasting because the starvation will lead to, again starvation will lead to the ketonuria and the ketoacidosis. So she should not be starved at any time. She should take the regular meals. She should take the regular snacks, so the her glycemic control will be optimized. What about the exercise? Ask the patient to have the walk half an hour in the morning and half an hour in the evening. Regular walk is enough. For this will causes the utilization of the glucose and the increase insulin sensitivity. What about the insulin and the oral hypoglycemic? Use is individualized. एम हमारा क्या होना चाहिए? अब ये हार्ड एंड फास्ट नहीं है कि हर पेशेंट को ओरल हाइपोग्लाइसेमिक दें और हर पेशेंट को इंसुलिन दें. This is depend upon the, if the patient has the control of blood sugar by the diet, then there is no need of using the oral hypoglycemic or insulin. But if the control is not achieved by the diet and the exercise only, then you have to add the insulin, you have add the oral hypoglycemic depending. If the patient is taking the oral hypoglycemic, then metformin is the best drug, and this will be given 500 milligram twice a day. And our aim is to keep the fasting blood sugar level between 5.3 millimole 1 hour after meal, 7.8 millimole 2 hour after meal, 6.4 millimole according to the guidelines. So this is the cutoff level which is used all the patient while she monitoring her blood sugar level either on the diet, either on the hypoglycemic agent or on the insulin. Insulin should be used in all those patients in whom the sugar is not controlled by the diet, exercise, and the oral hypoglycemic agent. So that we start the insulin in these patients. And the insulin could be the regular insulin in the 3 divided doses or the long-acting insulin only at the in the night, or the insulin analog. This depends upon the choice of the diabetologist and the response of the patient to the insulin agent. Now, this is the recommended management of the GDM at the diagnosis of the according to the NICE guideline. So, according to the NICE guideline, if the fasting blood sugar is less than 7 millimole at the diagnosis and there is no complication, like there is no preeclampsia, there is no previous history of the macrosomia, or currently the baby is growing normal and the biometry is normal, there is no macrosomia, then the management is the 1 to 2 week trial of diet and exercise. As the patient, as we discussed, she should take the carbohydrate, the protein, and the fat, and low index carb diet, and have the exercise half an hour in the morning and half an hour in the evening. And then the recommended pattern of the blood sugar monitoring is the fasting and 1 hour post meal daily. ये इस तरह से करती रहे अपना 2 हफ्ते तक. If it is remain normal, so then in other patient, if the blood sugar is 6 to 6.9, but along with though it is a less than 7, but along with she has the complications like the polyhydramnios, या फिर आपको लगे कि macrosomia है, then insulin plus metformin in addition to the diet and exercise should be advised. Oral therapy or single dose intermediate insulin or long acting insulin, और मॉनिटरिंग किस तरह से करनी है? जो भी पेशेंट इंसुलिन पे होगा उसको फिर डेली करनी होगी अपनी फास्टिंग 1 hour post meal daily. ठीक है? If the fasting blood sugar is more than 7 millimole, and there is even no complication, but the fasting blood sugar is raised, then start with the insulin or metformin plus diet and the exercise. So the multiple daily insulin doses is required, and the blood sugar fasting and the postprandial should be started. Post meal should be started. We do this monitoring of the fetus. Fetal monitoring can be done by this clinically. That is the history of the female. We can ask the history. For the history, you can ask the fetal kick chart or the fetal movement. Any history of the vaginal discharge, vaginal bleeding, or any other problem. So clinically, by asking the history at every visit, you have to look for symphysiofundal height, whether it is corresponding to the gestational age or not, or it is a larger than gestational age or smaller than gestational age. How is the amount of the liquor amni clinically? What about the, did you able to feel the fetal movements and listen the fetal heart sound by the Pinard's fetoscope? So this is the clinical assessment of the patient by taking the history, by doing the examination, particularly the obstetrical examination. We have to check the weight of the patient is also at the examination. And we have checked the symphysiofundal height, fetal movement, assess the fetal movement, assess the fetal heart sound by the Pinard's fetoscope. And the ultrasound examination. As we discussed that if in antenatal period, the normal patient, those who have the no complication, require 3 or 4 ultrasound examination during their antenatal period. But those patients who have the high risk, they require more frequent examination, ultrasound examination in their antenatal period. And the diabetes mellitus or the GDM is one of the high risk group. So we may require the more fitter. First ultrasound, as we discussed, at 10 to 11 weeks for the viability number and all these things. The second ultrasound should be performed at the 18 to 20 weeks, and that ultrasound is known as the anomalies. As the congenital anomalies are quite common in the diabetes, but the congenital anomalies are common in the pre-existing diabetes, not in the GDM. Because the glycemic control, euglycemia is required at the time of the organogenesis. As we discussed that the patient with a GDM, they have the diabetes, they recognize or they diagnosed as a diabetic at the time of the second trimester. So usually they have the normal glycemic control at the time of organogenesis. So there is a least chance of congenital anomaly. The congenital anomaly risk is similar to outside the diabetes mellitus. So in the 18 to 20 weeks, they have the anomaly scan. And then later on, after the 28 weeks, they have the serial ultrasound examination, either after the 15 days or monthly for the biometry. Biometry is to assess to exclude the fetal macrosomia. What we do in the biometry, we do the bipyramidal diameter, assess the bipyramidal diameter, we assess the female length, we assess the head circumference and the abdominal circumference, and by this calculating, we say that this is a normal growth or this is the abnormal growth. So if you have any doubt in the growth of the fetus, or you feel that the growth is not corresponding to the gestational age, it is a more than gestational age, then we do regularly after 15 days. So this is the fetal monitoring. Apart from, if at any time you feel that there is a hypolyhydramnios, or you feel that the baby is growing larger, or you feel that there is a poor glycemic control, you should hospitalize the patient. These patients should not be managed in the outpatient department. They should be hospitalized for the fetal-maternal monitoring, and the fetal monitoring is by this ultrasound examination and as well as by the CTG and by the clinically, while in the maternal monitoring is by the using the blood sugar level at the, as we discussed, 4 times a day. What is the time and the mode of the delivery in these patients? If the, for example, if patient is a euglycemic, blood sugar is normal, then the time, there is no rigid protocol for the timing and the mode of the delivery, no rigid protocol, but the NICE recommend that the woman with uncomplicated diabetes, GDM, uncomplicated, means she is a euglycemic, should be offered elective birth no later than 40+6. पोस्ट मेच्योरिटी नहीं करवानी है पेशेंट को, 40 वीक्स 40 या +6 डेज तक पेशेंट को लेके आना है, उससे ज्यादा नहीं, बिकॉज यू डू नॉट नो, यू कैन नॉट प्रिवेंट द अनएक्सप्लेन्ड डेथ. सो 40 वीक्स होती है ईडीडी, तो ईडीडी तक तो हमें लेके ही जाना है उस पेशेंट को जो भी जीडीएम की है. सो एम क्या होगा, बिकॉज Why we are continuing the pregnancy? Because the maturity has occurred at the 37 completed weeks. But as the patient with the diabetes mellitus, their lung maturity, fetus lung maturity is delayed. That's why it's a better, and because of the delayed lung maturity, the fetus may be suffer, an infant may be suffer from the RDS and all the problem as we discussed, the hypoglycemia, hypocalcemia, hypomagnesemia, polycythemia, neonatal jaundice, all these things could occur. So it's a better to continue the pregnancy provided if the mother remain euglycemic. If fetal-maternal monitoring is a reassuring and there is a no complication, you can continue the pregnancy up to the 40 plus 6 days. 40 days is the gestation. Women with a complication should be electively delivered before this gestation, but a woman with a diet control GDM with a good control and no evidence of the macrosomia does not need the delivery before the 40 weeks, 40 plus 6 days. Women with a complication का मकसद ये है कि जो भी patient polyhydramnios के साथ है, those patient with a macrosomia, those patient with a preeclampsia or because of the preeclampsia there is intrauterine growth retardation, then you can deliver the patient at 38-39 weeks after gestation. जो हमने डिस्कस किया प्री एग्जिस्टिंग डायबिटीज में कि 38-39 वीक्स पे हमें डिलीवर करवाना है पेशेंट को. What is the intrapartum care? Intrapartum care is usual as patient is the euglycemic. अगर वो euglycemic है तो उसका केयर वही होगा जो नॉन डायबिटिक पेशेंट का होता है. Intrapartum maternal hyperglycemia poses the same risk to the fetus and the neonatal hypoglycemia in GGM as in type 1 and type 2. हमारा जो aim होता है ना intrapartum maternal control, glucose control का aim ही ये होता है कि fetal hyperglycemia and fetal hyperinsulinemia को prevent. अब देखिए कि fetal hyperinsulinemia होगा तो क्या होगा? मैक्रोसोमिया होगा. अब अगर फीटल अगर मेटरनल हाइपरग्लाइसीमिया होगा तो क्या होगा कि फीटल हाइपरग्लाइसीमिया, फीटल इंसुलिनीमिया होगा और वो मैक्रोसोमिया. लेटर ऑन जैसे ही न्यूनेट डिलीवर होगा तो ग्लूकोज नहीं जाएगा तो हाइपर इंसुलिनीमिया विल लीड टू द न्यूनेटल हाइपोग्लाइसीमिया. तो ये बहुत ही इंपॉर्टेंट है टू प्रिवेंट द न्यूनेटल हाइपोग्लाइसीमिया इन जीडीएम. तो हमें देखना ये है कि अगर इंट्रापार्टम पेशेंट एंटीनेटली जो है वो नॉर्मली है, इसका ग्लाइसेमिक कंट्रोल एडिक्वेट है, शी इज ऑन द डाइट और ऑन द एक्सरसाइज या ओरल पे या ओरल हाइपोग्लाइसेमिक पे है या डाइट और उसका एक्सरसाइज पे कंट्रोल है, then she should not require any type of the medication during the labor. During the labor, she can be managed as the patient who are the non-diabetic. But those patients who have the on the insulin in their antenatal period are those patients who are on the oral hypoglycemic. They require their control of the blood sugar by the oral hypoglycemic or the insulin. Then they require certain use of insulin and the dextrose during the intrapartum period. And again, the monitoring, as we discussed, that the blood sugar should be monitored every 1 hour. And the aim is maintained between 4 to 7 millimole per liter. उनकी पेशेंट की ब्लड शुगर जो है वो 4 और 7 के बीच में होनी चाहिए. अगर 4 मिलीमोल से कम है तो आप ग्लूकोज को बढ़ा दें, अगर 7 मिलीमोल से ज्यादा है तो आप इंसुलिन का डोज बढ़ा दें. और इंसुलिन होगी एज अ स्लाइडिंग स्केल ऑफ द इंट्रावीनस इंसुलिन एंड डेक्सट्रोज. एक तरफ आपकी डेक्सट्रोज की ड्रिप चलेगी, 5% या 10% डेक्सट्रोज होगा, 510% डेक्सट्रोज, 2 कैन्युला लगेंगे, एक में 10% डेक्सट्रोज होगा, दूसरे में इंसुलिन होगी, नॉर्मल सेलाइन में इंसुलिन होगी एंड पोटेशियम होगा, क्योंकि पोटेशियम एक्सैजरेट द एंट्री ऑफ द इंसुलिन इन द सेल्स. तो केसीएल होगा और उसमें नॉर्मल सेलाइन और इंसुलिन आप डालेंगे दूसरी ट्रिप में. और देन यू titrate the dose of insulin according to the blood sugar level. You have to do the blood sugar every 1 hour. And then your aim is to keep the blood sugar between 4 and 7 millimole per liter. If at any time you feel that the blood sugar is less than 4, increase the dextrose water, dose of the dextrose water, उसके drops बढ़ा देंगे आप. But if the blood sugar is a more than 7 millimole and you are giving the, for example, आपके जो चल रहे हैं 4 यूनिट इंटरनेशनल यूनिट, तो उसको आप बढ़ा देंगे, 4.5 कर दें या 5 कर दें या 6 कर दें, and then titrate it again with a blood sugar level. एम आपका यही होना चाहिए कि पेशेंट की ब्लड शुगर जो है वो 4 to 7 मिलीमोल के बीच में होनी चाहिए. Women who have not required insulin in the antenatal period are less likely to require the insulin in the dextrose. As we discussed, मैंने पहले ही बताया कि जो पेशेंट जिनको इंसुलिन और ओरल हाइपोग्लाइसेमिक नहीं ले रही थी एंटीनेटल पीरियड में, तो उनको इंसुलिन एंड डेक्सट्रोज वाली रिजीम नहीं रिक्वायर होती इंट्रापार्टम पीरियड में. Women undergoing the elective cesarean section are unlikely to require the intraoperative insulin and dextrose infusion if they have not required antenatal insulin. ये सेम प्रोटोकॉल होगा सिजेरियन सेक्शन में भी, वही होगा जो हम इंडक्शन ऑफ द लेबर में करेंगे या नॉर्मल लेबर के लिए करेंगे. यानी अगर वो इंसुलिन या ओरल हाइपोग्लाइसेमिक ले रही थी तो डेक्सट्रोज और इंसुलिन इन्फ्यूजन हमें देनी पड़ेगी. But if she's not require the insulin in the antenatal period, she usually not require the insulin and dextrose in the this during the surgery. But the aim of the surgery, क्या करना है aim surgery का, कि the aim is that the elective cesarean section should be in the morning. Morning में सबसे पहले diabetic patient का ही सीजर करना है, because she may become hypoglycemic. She may become the ketonuric, she may become undergo to the ketone acidosis. So it's very important कि starvation हमें नहीं करवानी है पेशेंट को, ठीक है. जितना भी ज्यादा हो सके वो अर्ली मॉर्निंग में उसका हमें सिजेरियन सेक्शन करना होगा. And the what is the again the things which is important, as soon as the baby is delivered, immediately the baby should have the cord blood sample for the blood sugar. And if the baby's blood sugar is less than 20 milligram, the IV infusion should be started. Otherwise, all the patient with the baby's blood sugar is 50 or 50 milligram or 60 milligram, earlier feeding should be started. These babies, the recommendation is that the feeding is earlier requirement. What about the postnatal care? Initially stop all the hypoglycemic agent and the insulin as soon as the baby is born, because as soon as the placenta has been removed, the baby is born, there is a reduction, 50% reduction in the requirement of the insulin and the hypoglycemic agent. And so all the hypoglycemic agent and insulin should be stopped after the birth, and monitor the blood sugar in early postnatal period, pre-meal and the bedtime, until the blood sugar return to the normal, that is a 4 to 6 millimole per liter. And this should be without any, this monitoring means that the patient having the no insulin, no oral hypoglycemic, she just control on the this diet only. Because the breastfeeding further decrease the requirement for the insulin and so we must discuss the contraception at the same time. The contraception, the patient depend upon the type of the contraception. If she is choosing the breastfeeding to a baby, then the CUC are contraindicated because they reduce the milk secretion of the suppress and lactation. So ask the patient to have the barrier method, or the POPs, or the injectable contraception, or they have completed her family, they can have the permanent method of the contraception. Or if they wish to have the long contraception, then they can have the Marina IUCDs, the copper T, or the Marina, or this JDL. One can have the long-term contraception. But if the patient is a diabetic or she is a GDM, ask them to complete their family as earlier as possible. As in the GDM, these patients in the next future 5 to 10 years, they develop the type 2 diabetes mellitus. So all these patients are asked to complete their family earlier, but she should have the contraception for the 2 years, at least for the 2 years, to rear her baby, to optimize her health. So 2-year contraception is required those who has not completed their family, but those who has completed their family, it's a better to have the permanent type of the contraception. What is the postnatal care? In all these patients, the women who have the GDM are at a high risk of developing the type 2 diabetes in the future. ज़्यादा 5 से 10 सालों में उनको type 2 diabetes हो जाती है. This can be reduced by the lifestyle modification. उनको कहना है कि अपना weight reduce रखें, exercise करें, diet का ख्याल करें, तो it can be prevented. Women should be screened for the diabetes at the 6 weeks postnatal checkup with a fasting plasma glucose and annually thereafter. जो भी patient GDM की हैं, उनको बुलाना है at the 6 weeks in the postnatal checkup के लिए, और उसमें जब postnatal checkup के लिए patient आएगी तो fasting plasma glucose होगा and annually thereafter हर साल. All the women should receive the postnatal advice regarding the contraception and planning their next pregnancy. जो मैंने अभी डिस्कस किया कि जितने भी पेशेंट हैं contraception की, आपको उसी वक्त डिस्कस करना है पेशेंट के साथ कि अगर उसने अपनी फैमिली कंप्लीट नहीं की है तो 2 years contraception is enough, and then she plan their next pregnancy, और वो भी next pregnancy भी planned होगी. फिर जैसे मैंने कहा कि वो 6 weeks और annually वो चेकअप करवाएगी तो हमें पता चलेगा कि whether she is developing the type 2 diabetes or not. अगर वो type 2 diabetes में चली गई है यानी प्री एग्जिस्टिंग डायबिटीज है तो उसका वो उसी मैनेजमेंट में आएगी जैसे प्री एग्जिस्टिंग डायबिटीज है, यानी वो उसकी प्रेगनेंसी प्लान्ड होगी. वो प्री प्रेगनेंसी असेसमेंट और फिर उसके बाद यूग्लाइसीमिया, once she optimize her health then she get pregnant, and then the management in the pregnancy जैसे हमने डिस्कस किया था प्री एग्जिस्टिंग डायबिटीज मेलाइटिस में. अच्छा, ये रिकमेंडेड पोस्टनेटल टेस्टिंग है एंड एक्शन विद जीडीएम. जो भी पेशेंट जीडीएम की आएंगी उसकी पोस्टनेटल टेस्टिंग किस तरह से होगी कि मैंने बताया कि फास्टिंग प्लाज्मा करनी है, ग्लूकोज रिजल्ट if it is a less than 6 millimole or and hemoglobin A1C is less than 5.7%. recommended action क्या है? Advise that there is a low chance of diabetes at present. Continue with a lifestyle as they have moderate risk to develop the type 2 diabetes. So if the hemoglobin is A1C is less than 5.7% and the fasting blood sugar is less than 6%, that there is a low chance of diabetes at present. But as she has suffering from the GDM, then that's why she have to keep her lifestyle modification. यानी कि she should have the exercise, walk, and the diet and control her weight because she has a moderate risk to develop the diabetes mellitus. If the fasting blood sugar is between 6 to 6.9 millimole and the hemoglobin A1C is 5.7 to 6.4, high risk for developing the type 2 diabetes. Offer advices and intervention with according to the NICE guideline. जो NICE guideline ने type 2 diabetes mellitus के लिए बताई है advices, वही उसको करनी है. ठीक है, annually वो करे, अपनी lifestyle modification करे, अपना weight control करे, अपनी blood sugar जो है वो control करे. So this can be done by this according to the guideline. And if the patient having the 7 millimole, हमारी जो समझे 6.5 पे आप समझ लें कि she has the risk of the diabetes, उसको हम लेबल कर देते हैं कि she is known to be the diabetic. 7 millimole जो fasting blood sugar है या 48 millimole or more जो है hemoglobin A1C है, इसको तो आप समझ लें कि she is a type 2 diabetes. डायग्नोस्टिक टेस्ट उसको करवाना चाहिए, दैट इज ओरल OGTT करवानी चाहिए उस पेशेंट को, और कट ऑफ के हिसाब से उसको फिर यू हैव टू रेफर द पेशेंट टू द डायबिटोलॉजिस्ट. सो दिस इज ऑल अबाउट द diabetes mellitus, the pre-existing diabetes mellitus and the GDM. Now if you have any question. Question Who's asking the question?
मैम
Yes.
मैम आपने अभी बताया था कि मोड ऑफ डिलीवरी में कि 40 वीक से पहले डिलीवर करवा लेंगे, तो मैम ये बात थोड़ी समझ में नहीं आई तो क्लैरिफाई थोड़ा।
ओके मैंने ये बताया कि if the patient is the euglycemic, if the patient's blood sugar is controlled, she's her euglycemic का मकसद ये है कि बिल्कुल कंट्रोल है ब्लड शुगर, either on the diet and exercise or the oral hypoglycemic or insulin. पर ज्यादातर ये जीडीएम उसी के लिए, उस पेशेंट के लिए जो डाइट पे कंट्रोल है, जिनकी ब्लड शुगर और उनको कोई ओरल हाइपोग्लाइसेमिक या इंसुलिन नहीं लेनी पड़ रही है, तो उन पेशेंट को आप 40 वीक्स तक लेके जा सकती हैं, क्योंकि उनमें फिर अनएक्सप्लेन डेथ के चांसेस बहुत ज्यादा कम होते हैं। लेकिन जो पेशेंट इंसुलिन पे है या जो पेशेंट ओरल हाइपोग्लाइसेमिक पे है, प्रोवाइडेड शी रिमेन यूग्लाइसेमिक एंड यू आर मॉनिटरिंग, तो भी उनकी प्रेगनेंसी आप 40 वीक्स तक तो ले जा सकती है, लेकिन उससे ज्यादा नहीं। उससे आगे जैसे नॉर्मल पेशेंट होते हैं ना, उनको हम देखें 40 वीक्स तो ईडीडी होती है, तो हम 2 हफ्ते और छोड़ देते हैं उनको कि ठीक है, टू गिव द मैक्सिमम चांस फॉर द नॉर्मल स्पॉन्टेनियस वजाइनल डिलीवरी। लेकिन ये जो डायबिटिक पेशेंट है, उनको हम पोस्ट डेट या पोस्ट मेच्योरिटी में नहीं जाने देते, क्योंकि देयर में बी द चांसेस ऑफ द माइक्रोसोमिया, देयर में बी द चांसेस ऑफ अनएक्सप्लेन्ड डेथ। तो रिकमेंडेशन क्या है कि ऑल दीज पेशेंट, दोज हु आर इन द डाइट, they should be delivered at the 40 weeks, completed 40 weeks. Those patients who are on the insulin, they should be delivered between 39 to 40 weeks of the gestation, not more than this, to prevent the chances of the unexplained IUD. Clear?
Yes, ma'am.
Any other question? Any other question? This is clear to all of you? Can we stop it? Can we stop it? Is there any question? No? Okay. Okay.